Hello, hello, everybody. Good evening to you. January 5, it is a new year. Happy New Year. Welcome to another episode of Eclipse Unscripted. I am your host, Dr. Leek. And tonight we are going to talk about, well, I would say it's the stigma of addiction. You know, we just got done talking with Keith not too long ago regarding the stigma of alcoholism as it relates to pain management. And certainly there's a lot to be said there, and even more so, I think, with regard to the greater understanding of addiction as a whole. And so that's what I want to do tonight. I want to zoom out and talk about how people deal with addiction, if they have a friend or a family member, how they approach that situation. And then also at the end of this talk, I'm going to give you guys some tips on how to approach your pain management doctor as well, in case you find yourself with a history of addiction, whether remote or active, and hopefully you can communicate effectively with your team member, your physician, and get some good care. All right. So to begin with, how do we talk about pain and addiction? How do we talk about addiction as someone who doesn't necessarily struggle with addiction? If you're watching this, how do you approach someone who is dealing with addiction? See, I think the problem really persists across the board, that addiction really is treated still as a moral failure, right? We say things like, I don't understand why they would choose this. Don't they understand that they're hurting me? Man, they're so weak. How come they can't make better decisions? They're so selfish. What's striking about that, and perhaps even more uncomfortable to say, is a lot of physicians, not only do a lot of physicians do this, but family members, especially spouses, children, parents. It's very hard to understand why their loved one would seemingly make deliberate decisions to hurt their lives and everyone around them. So, the issue is even further. When someone enters a relationship, right, now it becomes even more, you might say, cruel, right? One person is right and one person is broken. One person is the victim and the other person is the villain. And that can be extremely damaging. But the truth is, addiction doesn't grow in a vacuum, right? It grows in an environment of shame, fear, isolation, unmet or untreated pain and suffering. And neuroscience has been very clear on this. Addiction is not a failure of willpower. It is a maladaptive survival response. We're talking about repeated exposure to substances that alter your brain chemistry, your reward circuit, your stress response system, your executive function, your impulse control, your decision-making capacity, and your emotional regulation. See, over time, the brain is regulated not to just feel good, but to feel less bad. And at that point, once that wiring has set in, choice becomes constrained, not absent, but impaired. And we know this from functional MRI studies. When we're looking at the size of your brain, the parts of your brain that are responsible for decision-making, right? Your prefrontal cortex and your frontal lobes, the part of your brain that says, no, maybe that's not a good idea. That part of your brain actually shrinks, physically shrinks in patients who are suffering from addiction. So, you know, we don't blame Parkinson's disease patients for having tremors. Why are you choosing to have tremors? We don't blame depressed people for choosing despair, right? Why is it that we're choosing to blame people with addiction, that they're just choosing this horrible and self-destructive life? That's not very appropriate, but there is a reason why we do it. It's because moral explanations are easier. It's true. If addiction is a moral failing, then it's safe, it's contained, it's their problem, right? But if it's actually more of a complex, relational, trauma-linked neurobiochemical disease, then it's complicated. Then we are forced to ask harder questions. What did we miss? What did we ignore? Why did we respond with anger rather than curiosity? What hidden pain did we not identify in that person? And then it becomes more complicated. But the truth of the matter is, shame does not produce recovery. It just doesn't. Shame has never, ever contributed to a positive patient outcome, whether in relationships, between family members, between children, spouses, but also between physicians and patients. Shame worsens the relapse risk. It worsens secrecy. It worsens isolation. And honestly, shame kills. And that's the big problem with that. That's the whole problem with identifying addiction as a moral failure. So many people then with addiction, they don't need to hear this. They already know. We already have, and I say we because who doesn't have an addiction? You already have an internal dialogue going on in your brain. I'm not good enough. I'm failing at life. I'm hurting the people around me. I'm worthless, right? That internal dialogue is already going on. And once there is external stimulation and validation to that internal dialogue, now we have a new identity. That identity is cemented now, right? And it's not a good identity. And honestly, that's what contributes so strongly to the lack of recovery, right? So there's this new villainous identity, and it prevents reconciliation. It prevents relationships from improving, and you ultimately have relationship collapse. And it's not because addiction existed. It's because repair was not possible. Certainly not with that identity. Forgiveness is conditional. Grace is transactional. And the goal then becomes punishment rather than healing. So there's a tremendous power that goes on with how we identify, how we refer to, how we approach a patient, a person with addiction, because everything is stored in that identity. They don't need to be told that they're making wrong decisions. They know. That's the problem. So we need to change the language because actually words do matter. We need to stop saying addict. I don't refer to my patients as an addict, right? And neither should you, and neither should other doctors. They're people with addictions. Simple as that. I know we refer to people as diabetic, but for some reason there seems to be less stigma behind that, even though that's more common. Maybe that's why there's no stigma behind it, or less stigma. But really, there are people with diabetes the same way. We should treat people with addiction the same way. I don't like to use the words clean or dirty, right? Again, that implies some level of disgusting sort of interpretation. Rather, we say a person is in recovery, or a person has recovered, or a person is actively using. It's just much more straightforward. The term relapse, right, often is framed as this idea of failure, right? Oh, well, he was doing so good, but he relapsed. So I guess he's not really good. He really doesn't mean what he says. He's really not as strong as we had hoped. No, relapse is a data point. Relapse is expected. Relapse is a part of the disease process. So if it's reframed in that way, it pulls some of that stigma out of it, right? Second, we need to separate accountability from dehumanization, right? You can hold boundaries without humiliation. You can demand change without contempt. You can protect yourself without destroying someone else's dignity. And that needs to be understood, especially in relationships. And that can be very difficult to do, but it's so important to leave a path open to a recovery position, right? Third, we need to treat addiction as a systems problem rather than a solo defect. So we know that recovery is improved when families are educated, support systems are activated, expectations are realistic, and shame is removed from the equation. It's just that simple. But again, it does take conversations like this to be able to understand that and approach that person with love and the care that they need. Fourth, and this is critical, we need to allow repair to be accepted. Some relationships fail because the addicted person not because the addicted person didn't try hard enough, but because no amount of effort was ever going to be enough. If repentance is never allowed to land, if change is never permitted to count, then the addicted person's true identity is never realized. And recovery becomes performative and hollow. So I happen to believe that we're all children of God. We all have fallen short of the glory of God. And as long as everything is approached in that context, there's always room for improvement. If the context is always, you know what, you suck, you're horrible, you make all kinds of horrible decisions for yourself, for your family, you try and you fail, you try and you fail, you know what, you're a failure. Okay, then I'm a failure. Where's the incentive to improve? You have to leave a path to reconciliation. And finally, we need to remember that people are more than their worst coping strategy. We must stop asking, what's wrong with you? And start asking, what happened to you? And how do we help you heal? Okay? The opposite of addiction is not sobriety. The opposite of addiction is connection. And stigma destroys connection every single time. So that's my 2 cents on helping somebody else with addiction. Now let's say you're the person with addiction, or maybe you are afraid of being stigmatized because of addiction, even if you don't have an addiction, coming into a pain management clinic. So now this part of the show is for you. Stigma in pain medicine is real. We talked about it before with Keith and how it relates with alcoholism specifically. Of course, opioid addiction is the elephant in the room that I'm sure we'll be talking more about. It's a pretty hot topic. And unfortunately, the experience is probably the same across the board. Patients with a history of addiction, they walk into a clinic, already their blood pressure is up, their heart rate is up, their anxiety is up, and they are preparing for the onslaught of judgment that is most assuredly to come. That unfortunately doesn't help anybody, but that's the reality of the situation. The goal here is not to make sure that you are able to prove that you are good enough for care. Actually had a patient ask that question, I think, in one of the comments here lately. And by the way, I love all your comments. Please keep them coming. And if you haven't already, take the opportunity to like and subscribe to this channel. That would certainly help out somebody else perhaps that needs to hear these words. So get our message out there. I appreciate that. And please leave a comment. Somebody left a comment, like I said, how do I prove that I'm good enough? How do I prove that I'm not a risk? Well, you don't need to prove that you're good enough. I think there's ways in communicating that can put your physician at ease, and that's what we're going to talk about. The goal is to help you advocate without escalating, communicate without defending, and protect your dignity while still advocating for appropriate treatment. So the first thing, actually, hold on, I'm going to tell you real quick. I have a total of 6 action items that you can do the next time you visit your physician. Number 1, reframe the narrative before you walk in. See, a lot of times patients come in and they're like defendants, right? They say, please don't think I'm drug seeking. Okay. If I told you, please don't think of the color yellow, what are you going to do? Think of the color yellow. So even though your intent may be good, immediately flags go up. Please don't think I'm drug seeking. Well, why would I think you're drug seeking, right? Don't say that. Say, I want to work together to manage my pain responsibly. Okay. Right off the bat, I'm thinking, all right, this person wants to be on my team, which means I want to be on this patient's team. Sounds like a plan. And they want to manage their pain responsibly. Okay. I don't know exactly what that means. I don't know if they know exactly what that means, but I know that we're going to be getting to somewhere good. So automatically that puts you into a better place of negotiation, let's say. That tone alone, that mindset alone will change your posture, your word choice, and your perceived credibility. So definitely come in wanting to work with the physician. All right. Number 2, lead with function, not suffering. I think a lot of patients that come in and they feel like they need to put on an act. Now, I'm not saying that the patient's acting, and I'm not saying that the patient is not in pain, okay? I'm a chronic pain trained physician. I understand that a 10 out of 10 pain for a chronic pain patient looks different than a 10 out of 10 pain for an acute pain patient. So if you are legitimately crying in pain, by all means, and I'm not saying don't do that if you have to, but don't feel like you have to in order to convince me your pain is truly a 10 out of 10. Honestly, because I really don't read into that 10 out of 10 scale very much. I really don't. I kind of think it's worthless. Sorry, government, but it's true. I do use it to trend scores over time. So if somebody comes in at a 10 and then maybe 6 months down the road, if they're giving me 5s or 4s, okay, I can look back and say that makes a big difference. Okay, fine. Sometimes I use the pain score in direct questioning. So for example, if I say, right before you take a pain medicine, how do you rate your pain? Well, it's a 7. How do you take it afterwards? Or how would you rate your pain after you take your pain medicine? Well, it's a 3. Okay. I know in my head then at least that medicine is reducing your pain by at least, let's say 50%. Good deal. If it's only going from a 7 to a 6, let's say, then that tells me, well, maybe the medicine isn't strong enough. Maybe we need to change the medicine, change the dose, change the frequency, something along those lines. So that's really the only benefit of the pain scale. But you don't feel like you have to come into that visit saying, hey, my pain is 10, give me strong medicine. I really don't read into it that much for the chronic pain patient. What you should do is communicate your level of function to your physician. So you can say, my back pain is so severe, I can't pick up my grandchild anymore. I just have to stand there and look at him, right? Or my pain is so severe that I can only do the dishes for 5 minutes, but it's not long enough for me to be able to finish the dishes, so I have to sit down and rest and then go back and finish it, and then it can take me an hour and a half to do the dishes when it used to take me only 20 minutes, right? So being able to explain your pain in terms of function is going to be huge because it gives me all kinds of great things to document. It gives me all kinds of great things to picture as far as how your pain is affecting your life. And it gives both of us some great goals to achieve, right? If I say, okay, now we're going to do treatment A, treatment B, treatment C. Again, the pain score may be the same throughout all of this. But if you're able to tell me, but now I can carry my grandchild around the house. Now I can play with them at the park and push them on the swing. Now I can do the dishes and my wife's not getting mad at me for not doing the dishes, right? So that is tremendous when it comes to dealing with the stigma of really pain management in general, but certainly if addiction is involved in that. Number 3, acknowledge your addiction history calmly, right? Avoid over-apologizing. Avoid, self-flagellation to the point where, it's like, okay, just starting to feel like you're trying to sell me a story here. Just be calm, be direct. Excessive shaming of yourself really does raise some flags instead of lowering them. So just, regulate before you advocate, right? And so much of that, again, is just a natural response to going to the doctor. Your blood pressure goes up, your heart rate goes up. They call this white coat syndrome. But especially if you're trying to advocate for a certain pain management care, whatever that may be, and you don't want to be put into a category of potential red flag by your pain physician, then just be cool, calm, and collected. Acknowledge what's been done, what you've tried, what's worked, what hasn't. And when you approach it in that manner, in a collaborative approach, it's going to just push you so far. If you need to write things down ahead of time, practice some breathing exercises, maybe bring a trusted friend or family member to kind of be an advocate for you or speak for you if you don't feel like you're able to, then that's definitely recommended. Okay. Number 4, ask for structure, not exceptions. So every patient, it seems, thinks that they're the exception. Well, please, doc, can you just do this thing for me? I know that's not how you normally process things or treat patients, but I promise I'm different. I'll make sure, to be better. While I appreciate that, it really doesn't get you anywhere, because guess what? I'm going to go to the next room and the next room and the next room after you, and y'all are going to sound the same. So you should rather advocate for structure. So that looks like treatment agreements, functional goals, objective monitoring, stepwise escalation. These are big words for essentially saying, hey, I want to be a part of your pain program. I want specific, stepwise approach to things. I'm open to trying multiple different things if it's going to help my pain, right? Because that's why you're there, to help your pain. And you want to do it safely. And you talk about saying things like, you know what, I realize that this might be higher risk. I'm willing to come in more frequently for pill counts. I'm willing to come in more frequently for drug screens. I'm willing to go and talk with my therapist on a more regular basis. I'm willing to do journaling in order to, see if I can uncover some deeper meaning in regards to my suffering. So, right, these are the things that promote collaboration, trustworthiness, reciprocal trustworthiness, and it's definitely going to get you into a better place than just saying, well, please just take a chance on me, doc. As much as I might want to, you're not special in that way. So hopefully those things will help. Structure signals reliability is the key there. The last 2. So build a care team that reduces single provider risk, right? So again, no doctor wants to bear all of the risk. Certainly not in today's day and age, and certainly not in patients that might be considered higher risk than others, right? A lot, I would say every patient really, because everybody's so subspecialized now. I mean, everybody has a primary care, but even primary cares are good at bringing in specialists, right, when necessary. And so I think that for any patient, there should be a collaborative approach, but especially for a patient that might be considered high risk for whatever nature. And so by you knowing that as a patient who might be at high risk, you can come to the table with that and say, hey, I already got a primary care that's real great and helps me with these things. Now I need a pain management, but I also have a neurologist to help me with my nerve problems, or a rheumatologist to help me with my joint problems, or a psychiatrist or psychologist to help me with my mental health and coping skills, right? And so by bringing more care providers, let's say, to the table, and you being proactive about that, that's going to signal, again, that you're serious about getting better, and you're showing your pain doctor that your pain doctor is not alone in this, that everybody is involved in your care. And what that's going to do also is protect you by reducing the potential for bias and unfair treatment, right? It's much harder to pull the wool over another physician's eyes, let's say, than just a single patient. And so I think that having multiple providers on your team is going to advocate for you as well. Finally, number 6, for those of you hanging out to the bitter end, I appreciate that. So again, if you are, despite practicing all of these things, if you do feel that perhaps your stigma of addiction is preceding you, let's say, perhaps you're receiving unfair treatment, or you are perceiving that you're receiving unfair treatment, call it out. That's okay, but do so calmly. All right. There's this idea of non-confrontational naming. So an example of this might be, I'm sensing some hesitation. I want to understand how we can move together safely. Just ask your doctor that, right? Just be like, hey, I think that maybe you, like I'm the patient talking to the doctor, maybe you feel unsafe about something that I'm requesting, something that I might require or am asking a question about. Maybe that would be good for my health, my pain treatment, my recovery. Can you educate me a little bit more about what those risks are? That invites dialogue, right? I think a lot of times, and I've heard this from patients coming from other physicians, they kind of just get the cold shoulder. Well, you're not a candidate. Oh, you're too high risk. Oh, you did this, so we're not part of that program anymore. If you've had one of these examples, leave me a comment. The more examples I have, the better armed I am to help other patients, right? But I hear this not infrequently. One time, a patient was in the hospital and missed her monthly follow-up, and by like 2 weeks. And then, but apparently that message didn't get to the clinic. So then she showed up to her appointment for her medication refill, 2 weeks late. And they said, well, you missed your last appointment, so we're not giving that to you anymore. Well, hold on. Let's have some dialogue. Let's talk about this. Clearly you don't know the whole picture. So again, a lot of times it's perhaps the physicians making knee-jerk decisions in response to information that they don't fully understand, or it is information they fully understand and the patient doesn't understand what's going on behind the scenes. So just invite that dialogue, call it out. Don't be afraid. Again, if your doctor's not willing to listen to you and you're being cool, calm, collected, and respectful, then, dude, you need a new doctor. That's the whole point. I can't help you if you throw the desk over and start screaming and yelling and everybody in the waiting room is concerned for their life. No, that's on you, unfortunately. But if your doctor's not listening to you and you're being respectful, then unfortunately, no. As physicians, speaking for everybody, we need to do better than that. So that is my monologue for tonight. Hopefully that provides you some insight into, unfortunately, what addiction is for a lot of people, what the stigma of addiction is for a lot of people. And hopefully you have some insight now into how to manage that better, not only for somebody else in your life that may be dealing with that, but also as a patient going into the healthcare system, especially pain management. It is a new year. Kevin, do we have any questions in the comment section tonight?
Actually, we do. I see Chris here. He's asking a really interesting question about having a gastric bypass or gastric sleeve.
Yeah.
Would it be recommended to, offer a higher dosage or more frequency?
Okay. Well, thank you for that question. Yeah. So, and for the record, again, this show is purely for entertainment and educational purposes only. So, what I'm about to say cannot be considered medical advice, but I will explain to you exactly how I approach, let's say, opioid therapy in regards to the need for additional medication, right? So going back to my earlier example, if somebody comes...
And by the way,
yeah,
this was due to absorption rates.
sure. Yeah, absolutely. Great question. So, yeah, in general, if somebody comes in and they're telling me, well, doc, I take my pain medicine and my pain goes from a 10 to a 5. Great. That's a 50% reduction in pain. And by the way, that's my threshold for determining whether a dose that is a milligram dose is appropriate. If there's about a 50% reduction, I don't want a 100% reduction. I know like the idea is that your pain should go all the way away, but when it comes to treating chronic pain, you need to undershoot. If you're getting 0 out of 10 pain from a 10 out of 10 pain, that medication is too strong. Okay. It is what it is. We're all humans. We all need to experience some pain. And so that's how I manage that for long-term use. So 50% or more reduction. But then they're like, but doc, it only lasts 2 hours. Well, if it only lasts 2 hours, then I'm probably going to do a genetic test, because it should last 4 to 6 hours for most of these short-term opioid medications. Should last 4 to 6 hours. If it's only lasting 2 hours, we got a problem. It could be a genetic problem, right? And so we can do some genetic testing in the clinic. And if your doctor doesn't do genetic testing, you should ask for that. You can do genetic testing to see how you metabolize these drugs. Some patients don't metabolize them and they don't work. Some people metabolize them too quickly and they burn out after an hour or two. And so understanding that will help us understand why you're experiencing that and then help direct treatment. Alternatively, let's say that happens, we do all that. We may change the medication or we may increase the frequency. It's just that simple. We may change the medication or we may increase the frequency. Now, if your pain is only reduced by 20%, then again, we would look at the genetic testing, and then we would also consider increasing the dose or changing the medication. So that's kind of how that works. So in your particular case, it sounds like you're post-op, you've had a surgery, maybe you've been maintained on medication for a long time. Generally speaking, again, anytime a patient is maintained on opioids and then you have an acute injury or a surgery, it is expected that your pain is going to be increased for a period of time. And so then in that case, you would likely benefit from an increased dose of medication for that period of time. But again, that should only occur in discussion with your physician. So yes, as far as absorption rates go, with gastric sleeves, that can be affected. But again, everybody has such a variable response to these medications that I don't know that I would necessarily take that component into direct consideration other than my general approach as a whole. So hopefully that helps. But again, talk to your doctor about it. There may be some things that can be done there. What else you got, Kevin?
Is genetic testing a nationwide problem for insurance companies?
Yes, it is. More and more insurances are not paying for it. So this is kind of how it used to work. A lot of pain management clinics would do this in-house as a way to increase their revenue, right? And I think it was probably used less than responsibly. Obviously, if there's a financial incentive, the idea would be to test anybody and everybody that walked through the door. That can certainly increase or raise some flags, let's say, for the insurance payers. So what ended up happening is the reimbursements went down. It became sort of difficult to do in the clinic, and now it became outsourced a lot. And I still find a tremendous value in it, quite frankly. Anybody that's maintained on opioids in my clinic, I advocate to get that test done for sure. Or anybody really that may have a good likelihood of being on opioid therapy. Because again, it allows me to select the most optimal pain medicine for a patient, improve their outcomes, reduce the risks. But we outsource all that testing now. There are certain insurances that won't pay for it anymore. I won't go into that list right now because it's probably going to change tomorrow. But yes, it's becoming increasingly difficult to get that covered. I think a lot of people are just saying it's not medically necessary. Let me tell you how medically necessary this is, okay? I had a patient the other day. This is a true story. They came to me from another clinic. So actually, this person's been maintained on morphine for like 15 years. And then that pain doctor retired, so she went to another pain doctor. This new pain doctor, did not feel comfortable writing the prescription for morphine. Why? I don't know, but decided to change her over to hydrocodone, okay? And right out of the bat, this patient had more pain. It was the same dose, same equivalent dose, but way more pain. To the point where she was functionally declining, unable to care for herself or her family members, becoming more bedridden, ended up in the emergency room like on 2 separate occasions because her pain was so bad. She was with this new pain clinic for, maybe 4 or 6 months, something like that, long enough to really decline. And she kept going back to her doctor, begging him to put her back on morphine. And the answer was simply, we don't prescribe morphine. And that was it. Patient finally had enough, looked up another pain doctor, ended up in our clinic, and right off the bat, we put her back on morphine. She comes back to see me a week later. She's like crying in tears with happiness. She's so happy. She feels so much better. And I said, you know what? Let's get some genetic testing on you. I want to see what's going on because I think I know what's going on. And sure enough, this patient had a CYP2D6 deficiency, meaning that she wasn't able to convert hydrocodone to norhydrocodone, which is the active form. So hydrocodone by itself doesn't cause pain relief. Norhydrocodone does, but it requires your liver to metabolize it to that active form. And so basically for 4 to 6 months or however she was just on hydrocodone, she wasn't getting any pain relief. But her last doctor didn't do genetic testing, didn't do patient-centered care, essentially, because it was evident that hydrocodone was not working and morphine was. And so that's another example where blanket policies can really be harmful to patients. But I look at it as a way of saying, hey, individualized care is not only appropriate, it's necessary. This genetic testing is necessary to support this decision making, and she's been doing well ever since. So, yeah, it's a problem to get it covered. They don't think it's necessary. They think we can just kind of cycle through meds and find one that works. But honestly, I think that's an unfortunate way of doing things. Yeah. How are we doing? Anything else, Kev?
We do have another on the
I'm trying to load it up on here. I'm having trouble seeing it, but that's not for you.
Okay, no problem. I've got you here. So Mark says, do you think there's any chance pain management could utilize virtual or telehealth as technology grows?
Yeah, no, absolutely. I think, I think there's a role for it, Mark. So we actually opened our clinic in 2021, and looking back on it, that was probably not the smartest thing to do, because obviously everything was still impacted pretty significantly by COVID, and clinics were still being shut down actively because they couldn't make money, right? A lot of the procedure centers were closed, ambulatory surgical centers for periods of time. Doctors, anesthesiologists were, you might say, redirected to COVID care directly rather than pain management. So it was a challenging time to open a clinic. I actually read an article several years later that looked back on 2020 and 2021 specifically, and they said that was the worst time to operate a pain management clinic in history. And I was like, oh, good. Well, let's just open one, start one from scratch. That was smart. But yes, during that time, we did use our fair share of telemedicine because we had to. But I will tell you, care suffers because of it. Care does suffer because of it. Is it better than nothing, Mark? Yes, it absolutely is better than nothing. But I have to tell you, there is something to be said looking at a patient across the desk, face to face. There's something to be said feeling that person's vibe in the room, watching where their eyes go, watching what their hands are doing, watching how they move, right, from the chair to the exam table, from the waiting room to the exam room. And then, of course, the examination itself. A lot can be determined, actually, just by touching the patient. And I don't think you can replicate that in a telemedicine setting. So I think it's valuable, extremely valuable, to have telemedicine. Is it ideal? No. Not to mention the fact that it does make it challenging to perform random pill counts if you are forever virtual. It does make it challenging to perform urine drug screens if you are forever virtual. And then, of course, it will also depend on the state that you're in. Some states don't allow forever virtual, especially as it relates to controlled substances. My understanding is that Texas is one of them. So while we can do virtual visits for a time, on that third visit, we do have to have a face-to-face where I can see you in real life, touch you, examine you, do all the drug screen stuff, that type of thing. So no, how we use it now, I use it on an emergency basis. Bad weather, patient sick, or some other extenuating circumstance. But I don't think that you can match the value that is had on an in-person visit. Yeah. Yep. No, good question. And I know that's challenging. It's very challenging because, a big problem I think patients have is the need to be close to a pain doctor. I have several patients that commute, let's say, more than an hour, and it always raises flags with the pharmacy. We have a patient called and said, yeah, the pharmacy won't fill my medicine because they don't recognize your prescription because you're too far away. I'm like, I'm an hour and a half away. You live in the middle of nowhere, man. Is there another pain doctor closer to you? And actually had to call the pharmacy and argue with them. I was like, please tell me, for the love of God, who is this patient supposed to go to? And they're like, well, I guess, yeah, you're the closest one. I'm like, yeah. So before you deny my patient care, I understand, because again, they have to fully discredit the pharmacists, they do have certain regulations where, controlled substances need to be filled by doctors who are within a certain radius. I think it might be 45 miles or, don't quote me on that, but it's something relatively, short distance. And we were just outside of that distance. And anyway, so it flagged their pharmacy, but it's like, dude, look up who's around. No, but you live in the middle of nowhere. So anyway, that is a challenge, Mark, as far as making sure that you can get care that's from somebody near you. And, again, telemedicine is great and can be great especially for circumstances like that. But again, there are regulations that govern that. And it's just not as superior to in-person visits. Yeah.
This is just a curiosity question for me. So virtual is radius based as well?
Virtual is more state based. So wherever that doctor's licensed to practice. Okay. So I couldn't, being a Texas licensed physician, telemedicine treat a patient in, let's say, New York. Now, if that patient was a resident of Texas, then that would be different. But that's sort of where the jurisdiction falls on that.
Anywhere in Texas?
If you're a resident of Texas, I can treat you in Texas, anywhere in Texas.
So then is virtual kind of like a workaround to some of that?
Well, yeah, I mean, again, there's several benefits to telemedicine. You're talking the convenience factor, of course, or even finding the right physician that works for you, especially if nobody's around you, that type of thing. But again, the state itself has certain regulations. There may be exceptions to the rule. I'm sure there are exceptions to the rule, but where I'm located, there's no reason to apply those exceptions because they're pretty, large exceptions. You have to fill out, you have to check all the boxes to qualify for the exception. So we don't really need to do that, but yeah, that's sort of how that works.
Interesting question just popped in. So what if I'm on vacation in New York and my resident is Texas based?
Yeah, no, that certainly does come up. That is possible, although difficult. I've had it work sometimes. I've had it not work sometimes. I've had a patient in North Carolina need to come back to Texas in order to get care. And I've had a patient in Colorado that was able to get care over the phone. And so it just depends. It probably depends on what's on your driver's license. Well, certainly depends on what's on your driver's license. But it also depends on the pharmacy. Some pharmacies are okay with filling an out-of-state script for, let's say, a vacationer. Some pharmacies are not. I can tell you that typically that prescription will be a short-term based. So if you're used to getting 30-day prescriptions, probably it won't be a 30-day prescription. Probably it'll just be a 3-day or a 5-day prescription, something like that. But it is possible. Yeah. The main thing is that the doctor and the patient are both residents of the same state that the doctor is licensed to practice in. Beyond that, there may be other variables, but that's the main thing. Yeah. Some patients, also they've maybe spent quite a long time out of state, and maybe this is their second or third, attempt at getting some sort of prescription sent in virtually, and but at some point they have to be cut off or seek help from a doctor in that state, or make the trip back to their home state to get treatment, because again, nothing is indefinite in that case. It's an abnormal situation when a doctor is sending a script across state lines. So there needs to be some sort of exception to that practice. Yep. Anyway, I hope this was helpful for you guys. I do appreciate the time. I appreciate the questions. But yeah, please, again, if anything did come up that you'd like an answer to, maybe even just in comment form, not necessarily live on a video, leave a comment. If you think of something later on, put it down. The stigma of addiction is real. It's important that you find a physician that understands that, has empathy for that, and can approach the problem in a way that is mutually beneficial. And hopefully now you have tools as well to approach your physician with a little more confidence, a little less fear. It is a new year. Happy 2026. And here's to everybody living more this year with less pain. Until next time, have a good night.